My name is Dane Clutie, your physician assistant, and I will be talking about the initial management of orthopedic injuries, getting it right. I've been a PA for 17 years at New Hampshire Orthopedic Center in southern New Hampshire, a large subspecialty practice. I enjoy seeing patients with a wide range of musculoskeletal complaints. I really take pride in seeing any patient that walks through the door, whether it be foot and ankle to spine, just able to see all different types of injuries. And I have pride in that. And I think that's sort of a dying art these days where there's orthopedics is so subspecialized. We need more PAs that consider themselves more general orthopedists. I'm also editor of JBJS JOPA, a journal for orthopedic PAs, and I was the former president of the New Hampshire Society of PAs, and I continue to support the society as well. So the goals of the talk today, one, to avoid unnecessary referrals to the ED, which patients absolutely need to go to the ED or can be sent home and have a few days until orthopedic follow-up. You want to avoid keeping patients in the ER waiting for 6 hours unnecessarily. And again, which ones actually need to go to the ED, which ones are the emergencies, which ones need IV antibiotics or surgery. Talk about the types of splints and DME to use on what particular injury. I see that a lot. Patients come in with the wrong type of splint or the wrong type of DME for their foot injury. So hopefully we can clear that up today. Weight bearing status, so what patients need to use crutches and take weight off the extremity. And appropriate time frame for follow-up. Some people say, well, if it doesn't get better in the next 2 or 3 weeks, you can follow up with orthopedics, but understanding why patients need to come in 2 or 3 days versus a week versus 2 weeks. So we'll clear that up today. So throughout the presentation, I will go over some case studies to introduce diagnosis. And the first case study is about a finger infection. So this patient was a 12-year-old bitten by a cat 5 days ago, presented with worsening swelling, redness of the right hand. You can see the puncture wound at the DIP. Physical exam revealed uniform swelling, erythema, and warmth along the partially flexed finger. She had extreme pain to passive flexion and pain to palpation along the flexor sheath. So question is, what is the most appropriate management of this patient's current condition? Outpatient oral antibiotics, MRI, admission with IV antibiotics, urgent surgical drainage. And I will say that it's gotten worse over the last 24 hours. So this patient is presenting with flexor tenosynovitis, a can't miss diagnosis because this infection pierces through the flexor sheath and it can spread rapidly through the flexor sheath to the deep palmar space. The 4 Knavel signs are the hallmark to making a diagnosis. So if you have intense pain along the flexor tendon sheath to palpation, that's the most important physical exam finding. If the patient presents with a flexed finger, it's an obvious discomfort. If there's uniform swelling of the finger, so if the patient has a sausage digit, severe pain when the finger is extended. So if they have all these symptoms, physical exam findings, this establishes the diagnosis of infectious flexor tenosynovitis, which if presenting less than 48 hours with these increasing swelling and symptoms, IV antibiotics may be okay. If the patient's had these Knavel signs for over 48 hours, absolutely will need a surgical IND. You want to prevent the infection from spreading. And again, this could result, if the infection did spread, could result in skin loss, osteomyelitis, and risk of the finger needing an amputation. So finger infections on the dorsum of the hand don't quite spread as quickly and likely can be managed a little slower with a trial of oral antibiotics followed by hospital admission and IV antibiotics. If treatments fail, again, it's less likely to spread down the flexor sheath into the palmar space, like flexitina synovitis. Some take-home points with finger infections in general: get an x-ray to rule out a foreign body. Don't miss the canaval signs in flexitina synovitis. Human fight bites, polymicrobial, usually 5 bacterial isolates in these injuries, so broad spectrum antibiotics. Culture wounds whenever possible before starting antibiotics, and follow very closely. So the next injury is phalanx fractures, proximal and middle, as well as distal phalanx fractures, very common in the urgent care presentation. I see a lot of these with crush injuries at work, and we see them through the process, work-related injury. They can last for months. The most common is the distal phalanx, followed by the middle, and then the proximal phalanx. The biggest thing with these is patient education. We educate patients about nail growth and nail injuries, including the germinal injury to the germinal matrix, which provides most of the nail growth. So injuries to the germinal matrix may cause the patient to have an abnormal nail or no growth at all. Also, distal tip of the fingers have a lot of nerve endings, and for this reason, if you have a crush injury to the distal phalanx, you can have sensitivity for over 3 months or up to 3 months. So you have to educate patients with that in terms of work-related injury. And also, if the nail has fractured through it and become loose, it's important to provide a nail bed repair to prevent nail deformity. So I use aluminum foam finger splints on a lot of patients, provide excellent protection to distal and middle phalanx, but you can't use them for proximal phalanx because the splint usually cuts off mid-proximal phalanx. And so I use a lot of stack splints as well for distal phalanx fractures. Distal phalanx fractures, crush injuries, are really sensitive to the tip of the finger, so the stack splint provides that tip, that protection on the tip to the touch, so that it's hitting the plastic component of the stack splint when it comes in contact and not the tip of the finger. Also, I'll only use these splints for 2 or 3 weeks for distal and middle phalanx fractures. You want to get these moving as fast as possible, so we'll buddy tape them for another couple weeks. So only splint the fingers for 1 to 2 weeks usually, never longer than 3 weeks. So continuing on phalanx fractures, key is to look for instability, joint instability. If the fracture involves less than 40% of the middle phalanx, as seen to the right here, you can do extension block splinting, allow flexion, but avoid full extension, which makes the joint more unstable. You want to flex the PIP joint in 60 degrees. Surgical indications include extra-articular fractures with greater than 10% angulation and 2 millimeters of shortening, or any rotational deformity. Obviously, displaced intra-articular fractures. You don't want displaced intra-articular fractures. Basically, you'll end up with early degenerative arthritis if there's a step off in the joint. And any unstable shortening oblique type fractures. And you can see here to the right that some of the common surgical procedures include percutaneous pinning and screw fixation. So proximal phalanx fractures are a different animal. These are typically long oblique or unstable injuries, length unstable injuries. They're prone to shortening and rotation. So my initial treatment is a mitten type splint, as you can see here to the right, that goes all the way up to the tips of the finger, the distal phalanx, and immobilizes the entire joint all the way to past the MCP joint. So you want to immobilize the MCP joint as well, which essentially you have to use this volar mitten-based splint. I recheck x-rays every week for 2 or 3 weeks because these are prone to displacement. And if it's any type of rotational deformity, definitely get it over to hand surgery for percutaneous pinning versus screw fixation. But if it remains stable, I would treat it in a mitten cast for 4 to 6 weeks. So a quick case here on apparent finger fracture. A 61-year-old male was pulling his boat engine cord and caught his right ring finger, and it pulled back. He noticed immediate pain and loss of flexion at the DIP joint. Radiographs were obtained, shown to the right. So you can see this apparent avulsion type injury at the distal phalanx. What's the most likely diagnosis? Mallet, Jersey, tuft, or middle phalanx fracture? So this is a can't miss diagnosis presenting oftentimes in urgent cares or outpatient is a jersey finger. Typically occurs when you're grabbing something and you feel a pop of that distal phalanx. You can see here to the right, you've got that avulsion injury at the attachment of the flexor tendon. This is an avulsion of the flexor digitorum profundus, the tendon that attaches to the distal phalanx. You can have just a simple bony component to it, as you can see here, or it could be an avulsion of just the tendon, and the x-rays would be normal, and they would have this sort of inability to flex the distal phalanx. The most common finger to have this happen is the ring finger, as it's the most prominent, 75% of all jersey finger injuries. Treatment involves a direct tendon repair. So this is a surgical condition. So it's something you don't want to miss because it requires surgery. If you miss it, the tendon can retract and it can become irreparable. Can't miss diagnosis. Treatment of large avulsion fractures include open reduction and internal fixation. So if there's a large piece of bone, the bone has to be repaired, but oftentimes it's just a direct tendon repair. Another common injury in the urgent care setting, mallet finger. It's an avulsion off the extensor tendon of the distal phalanx as opposed to flexor like the jersey finger. Again, the tendon avulses off the base of the distal phalanx. Common injury in sports and work, the finger gets jammed. Treatment involves extension splinting at the DAIP for 6 weeks total. That's how long it takes for the tendon to heal back down. It has to be on for 24 hours. So as soon as they take the splint off and the finger drops down, then the 6 weeks starts over, as this disrupts all the healing. So we've had that happen before. Patients have come in, lost the splint. Now they have the sag deformity again. They have to restart the 6 weeks over again. We do surgery if there's bony involvement. If it's over 50% of the joint space, then that is unstable, has to be repaired. I typically like to use a stack splint, as you can see here, and just kind of keep that on. It's easier. It's sort of that waterproof type of compliant splint. And why orthopedic follow-up? Complications can arise, so it's important, if you take the splint off and the patient has continued sag, kind of being able to explain to them what to expect and how to treat from there on out. So it seems like a seemingly easy diagnosis, but it can have complications and worth an orthopedic referral. So next topic is fingertip amputations. I get a lot of calls from providers on what needs to be sent to the ER versus what we can manage at an urgent care facility. In general, fingertip amputations are non-urgent. There's really no need to send them to the emergency room. I know they look gruesome, but unless there's a reimplantation, there's a pediatric injury, or you just don't feel comfortable, I would recommend that these not go to the ER and unnecessarily. Initial treatment is usually irrigation and debridement with saline and in the urgent care clinic, followed by wet to dry dressings or a non-adherent dressing with a big bulky bandage, so that you don't get the phone calls from bleeding through the bandages later in the day or the night. Orthopedic follow-up in 2 to 3 days, so we can take off the bandages and assess whether the patient needs surgery or not. Treatment, it's remarkable how many of these can heal with secondary intention, just letting these kind of heal in on their own. If there's no bone exposed and less than 2 centimeters of skin loss, they generally do pretty well with just healing on their own. If they have bone exposed or a large skin loss, you can remove some of the bone with a rongeur in surgery generally, and perform a primary closure or a skin graft or flap reconstruction, a larger procedure. You can see here classic injury, table saw injury in a 62-year-old gentleman. Looks pretty gruesome. You can see some bone loss of the 3rd digit, distal phalanx, but ultimately, this does not need to go to the emergency room. Wet to dry dressing, follow up with orthopedics in 2 to 3 days. And just to review, partial fingertip amputations less than 1.5 centimeters without bone exposure, inadequate skin volally, often heal with primary closure or secondary intention, just kind of folding it right over the top and tacking it down if there's enough skin over the bone or enough soft tissue over the bone. And healing by secondary intention occurs generally in 4 weeks and is associated with less time out of work and fewer complications than a flat procedure. So that's really important that secondary intentions actually, healing by secondary intention actually gets patients back to work sooner. Injuries with exposed bone and limited soft tissue covered vollae often require removal of some or all of the distal phalanx to allow for skin closure. You can see here another case of a fingertip amputation. The initial injury, top left, the patient was placed in a bulky dressing. You can, if the tip of the finger is unstable, kind of just hanging there, you can also put them in a bulky dressing with a fiberglass splint to sort of hold it in place. The revision amputation was performed. You can see suture over the top there. And basically wound care, serial dressing changes, sutures out in 2 weeks. And then at 2 months, you can see really healed nicely. So they do well. Next, I'll talk about splinting and just go over a general technique that I use. So when I put on any splint, I'll set up a table on the side of the patient's bed and collect all my materials, soft roll, ace wraps, and stockinette. I'll then measure the extremity that I need to splint for the splint size with a soft roll. So basically take the soft roll out, measure it, cut the soft roll, and then bring the soft roll to the fiberglass roll and cut it to length accordingly. I usually use a stockinette on the surface of the skin there, as you can see. I think that really helps with avoiding any irritation to this synthetic roll, especially if the patient sweats. It's just much more comfortable to use a stockinette, so use that if you have it. Followed by 2 to 3 layers of soft roll, and make sure you use a little bit more over bony prominences as well. I then take the cut fiberglass. I'll open up the soft roll padding, as you can see on the right here, and you can see the fiberglass is sort of hanging over the edges. So what I'll do is I'll wet it, I'll lay it in the padding, and then I'll cut about 1 to 2 centimeters on either side, and that prevents patients, that fiberglass shards from rubbing on the patient's skin while they're in the splint. So very important to cut those short before you put the splint on, and then secure with an ace wrap. So some common uses for a thumb spica splint, as you can see here, goes over the radial side of the wrist to the tip of the thumb. You can use it for gamekeeper's thumbs, radial collateral ligament sprain, first metacarpal and proximal phalanx fractures. It provides better stability than the Velcro splint that you see at the bottom here. The Velcro splint I use for more long-term conditions like CMC arthritis, tendonitis, and trigger thumb, something that I'm going to use the splint for 3 to 5 weeks. The fiberglass splint's really used for about a week. So the only true fracture that I'll use this Velcro splint for, is a unicortical buccal fracture in pediatric patients. You can see here the buccal fracture of the distal radius, and on the lateral you can see it's unicortical. These are very stable fractures. I'll keep them on a removable splint for probably 4 or 5 weeks, and they always heal, no complications. And so you want to see orthopedics in 7 to 10 days after the initial injury, though, just to get another x-ray, make sure nothing's moving, and make sure you educate patients. So a bicortical buccal fracture is a little bit more unstable. It's really critical to look at the lateral, and you can see that on the lateral, the fracture line involves both cortexes. So those are a little bit more prone to displacement and more unstable. You cannot just use a removable splint for those. You have to put them in either a volar or sugar tong splint and follow up with orthopedics within 3 to 4 days or a week to re-x-ray and make sure that they're stable and to get a cast on. Definitely want to cast for a bicortical buccal fracture. But the initial treatment can be a splint. So this is a pediatric distal radius fracture that's displaced, 7-year-old Fuchs injury. And you can see it's a displaced bicortical fracture. Initial treatment should be a sugar tong splint, which is a little bit more secure for the displaced fractures. Orthopedic follow-up in 3 to 5 days. So then what I do is I see him and I put him in a cast, and I can mold the cast to reduce the fracture a bit. And you can see
about 4 or 5 weeks out, it's remarkable how much remodeling. You can see that extra strip of bone where it starts to straighten out the bone by um, laying callus on the curved side and taking away bone on the apex side. So that's the remodeling technique in this 7-year-old. Definitely straightens out the bone. I educate parents with that you can leave this the initial injury a bit displaced and it'll still heal fine and straight. So again, doesn't need to be sent to the emergency room for an urgent reduction. I can mold it in the cast, and then over time it straightens out with remodeling. Management of displaced distal radius fractures in adult. I get the phone call all the time. When is a reduction needed? Does he need to be sent to the ER? Basically, the only reason a patient needs to be reduced is if they have severe deformity, severe pain out of proportion. They have dense numbness, so the fracture is so displaced that it's sitting on the carpal tunnel. And when I say dense numbness, they can't feel their fingers. So if they can, any light touch sensation is fine. That's not dense numbness. So keep that in mind. Um, Otherwise, just splint it. This particular fracture was just splinted and sent to the back to our office in 3 to 5 days, despite significant displacement. But use your best judgment. If the patients want to go to the ER or you're uncomfortable with it, you certainly send it. But just in general, they don't need to be sitting in the ER for 6 hours waiting for orthopedics. They're just going to be followed up outpatient anyway. And of course, open fractures need to be sent to the ER. Basically, look for a little pin type hole around the fracture site that won't stop bleeding. That's an indication of an open fracture if it's not obvious. And again, this is not a superficial abrasion. The pinhole pokes are definitely open injuries if they keep bleeding. One injury to keep on your radar, an occult scaphoid fracture. Um, So this was a 34-year-old fall on an outstretched hand. Original x-rays were negative. And again, you don't send those patients and say follow up on a PRN basis. You definitely have to say, make sure if the pain continues that you follow up with orthopedics because the patient continued to have pain 2 weeks, still have pain over the snuff box, and the patient ended up getting an MRI 2 weeks after the injury and had a non-displaced fracture of the scaphoid. Again, these are prone to non-union displacement and potential degenerative arthritis, so it's something you don't want to miss. So any snuff box tenderness, throw them in a splint, thumb spike a splint, follow up with orthopedics in a week or two, and hopefully they're negative, but play it safe. So this is an interesting case of a missed scaphoid fracture. 15-year-old presented with wrist pain 4 weeks ago. The initial x-rays were negative on the left, and he was diagnosed with a wrist sprain and advised to follow up PRN and return to activities as tolerated after his symptoms had resolved. Certainly not what I would advise if clinically he has pain over the anatomical snuff box. Make sure that there is some sort of follow-up if he has continued pain, or you may just want to play it safe and have him follow up in general. At any rate, he presented to me 4 weeks after the injury. Repeat x-rays showed there to be further displacement of the scaphoid fracture with cyst formation, so that was headed in the wrong direction there. And I ended up casting him and he did fine. But the bottom line is don't rely on the x-ray report. Careful clinical exam. Look where he's tender on exam, look at the site on the x-ray, and you're less likely to miss something. So it's just a reminder to get an x-ray. If someone has pain in an extremity, get an x-ray. This patient came with wrist pain, chronic wrist pain, and odd diagnosis, pretty rare, but the patient had Kien's-Bach disease, osteonecrosis of the lunate. AP X-ray shows proximal migration of the capitate and fixed hyperflexion of the scaphoid, and you can see on the MRI here, basically avascular lunate. So you really don't know what you're going to see. Some of these zebras show up every once in a while, so get an X-ray. So next we'll talk about hand lacerations. This was a 19-year-old who presented to the ER with a thumb laceration. He was grasping a glass vase in his hand when the glass broke, cutting the base of his thumb.
On exam, the patient is unable to flex the interphalangeal joint of the thumb. In the ER, the wound at the base of the thumb was washed out and closed. He was sent for orthopedic follow-up, which is appropriate. Place in a thumb spike, a splint, bandage, and recommend orthopedic follow-up in 3 to 5 days. And when we saw him, he was diagnosed with a flexor pulsus longus laceration and subsequently had a operative repair. So to discuss flexor tendon injuries, which can be extremely complex, basically when you see a hand laceration on the palmar side, you want to test and isolate the DIP and the IP. So the FDP tendon flexes the DIP and the FDS tendon flexes the IP joint. Those are the commonly injured tendons. The tendon may look intact in the wound, but moving the finger may bring the injured segment into view. So even though you look at an intact tendon within the wound, that may not be where the tendon's lacerated. So you have to move the finger, and really it's unclear. It can be very unclear where the injury is. So play it safe and send hand lacerations for orthopedic follow-up. Any flexor tendon tear that's over 75% of the tendon needs to be repaired, and the repair should be performed within 2 weeks of injury, or if you delay treatment, the tendon can retract and it can be unable to be repaired if it retracts too proximally. So another case of a hand laceration. This is a 26-year-old butcher that presented to your office with a thumb laceration while cutting meat at work 2 weeks ago. The laceration occurred at the distal or just distal to the IP joint of the thumb. You can see here. He was sutured up and closed and sent home activities to tolerance. But then he started to notice that when he gave his kid a thumbs up at a soccer game, he could not extend the tip of his thumb, and later was diagnosed with a extensor pollicis longus tendon laceration. So you have to be very careful with this exam because this was a missed injury, and if during a careful exam you saw that he could not extend his IP joint, it would be concerning for the EPL rupture. So another extensor tendon laceration. A 22-year-old male presents with a stab wound to the forearm that occurred during an altercation 5 days ago. The knife entered the dorsal and distal 1/3 forearm on the ulnar side. And now, as you can see on the picture, he's unable to extend his ring, middle, and index fingers and thumb since the injury. And you can see really the extensor lags of those digits, and he can keep his pinky up, but the other fingers just fall right back down. Diagnosed with a extensor digitorum communis laceration, and subsequent had a tendon repair. So to summarize, hand lacerations, you really have to avoid missing these, and really needs to be early follow-up. So be careful with your exam. Flex and extend every joint individually. You can see on this picture the tendon anatomy of the hand on the flexor and extensor side is extremely complex. So perform a careful exam. Flex every joint, including the DIP, PIP, MCP joints, each finger individually, distal to the laceration. Look for extensor lag deformities of the hand, and any suspected injury should be splinted and have early orthopedic follow-up. So next we'll talk about pediatric elbow fractures commonly seen in the outpatient setting. This is a 6-year-old with a Fuchs injury. The initial x-rays questioned a proximal radius buccal fracture, but on physical exam, the patient had pain medially, and the radial capitella joint, as you know, is laterally, so that didn't make any sense. Didn't correlate with their report. I did comparison x-rays to the contralateral side, and you could see further displacement of the medial epicondyle on the injured right side. She was diagnosed with a medial epicondylar avulsion fracture, so the comparison x-rays helped me out here. Initial treatment for pediatric elbow, start with a long arm splint, follow up with orthopedics in 1 week, repeat x-rays. At this point, you can either cast or put in a sling. You really have to get these patients moving fast, so I'm more leaning towards the sling treatment for compliant patients. So basically stay in it, but get it out of the sling 2 or 3 times a day for a gentle range of motion. And this patient was treated with a sling for 4 weeks and did great. So to continue with pediatric elbow fractures, there are 6 ossification centers in the pediatric elbow, which can make it very difficult to interpret. You can see here a year of ossification when they actually appear on X-ray, the age, as well as the year of fusion. Um, so the medial epicondyle is the last to fuse, and it's prone to injury with avulsion type fractures and little league elbow when kids pitch and they have repetitive valgus stress to the elbow, which can cause physeal widening because the medial epicondyle hasn't fused yet, so it's a point of weakness. Also important to note that the occult fracture rate, negative X-ray, occult fracture rate is about 45% in pediatric elbow injuries with a positive fat pad sign. Most common fractures being supracondylar, lateral condylar, and medial epicondylar fractures. So if you have that fat pad sign, best to put them in a long arm splint. I would prefer that over a sling, as the sling can be taken off and the elbow can be moved and any fracture can displace. So a long arm splint initially is the best treatment. This is another pediatric case. A 5-year-old girl presents to an urgent care with left elbow pain after falling off the monkey bars a few hours earlier. She landed on the left hand with the arm in extension. She is unable to move the elbow since the injury. On physical exam, basically, she has global tenderness, difficulty with any motion. So the hint here is Montasia. What would be the most appropriate treatment? Sling for comfort, closed reduction and placement of a long arm cast, open reduction and percutaneous pinning, or open reduction and internal fixation. If you look closely at the x-rays, you've got a proximal ulnar fracture with a radial head dislocation. So that radial head dislocation needs to be reduced and the patient needs to be placed in a long arm cast. So answer is B. So this is a pediatric injury that keeps orthopedic surgeons up at night and really is a can't miss diagnosis here. So a 6-year-old female presents to the ED with severe right elbow pain and deformity after a fall from the monkey bars 2 hours earlier. Her right hand is pink and warm, but she has no palpable radial or ulnar pulses. So you can see here on the x-ray, you've got a displaced supracondylar fracture, which is causing vascular impingement or compromise at the elbow. And supracondylar fractures can be associated with a vascular injury. So this one needs to be brought to the operating room quickly, close reduced and percutaneous pinning, which almost always restores vascular perfusion. But you always have to check the distal pulses on these fractures because they can impinge on vessels. And make sure you document pink warm fingers with cap refill less than 2 seconds. Okay, now to talk about pediatric forearm fractures, very common, represent 40% of all pediatric fractures. Most of these do not require surgery and can be closed, reduced, and casted. And you can accept some degree of angulation even after reduction before skeletal maturity due to remodeling potential. So key here is watch for subtle open injuries though, small poke holes in the skin at the apex of the fracture. If you look at the chart here, you can accept a fair amount of angulation from 0 to 10 years of age, less than 15 though, less than 45 of rotation, and some bayonet apposition less than 1 centimeter. But as you get older than 10, you can accept less angulation and rotation. And as you get closer to skeletal maturity within 2 years, you can't really accept any degree of angulation and malrotation. So you have to have a perfect reduction in patients getting close to skeletal maturity. Topic is radial head and neck fractures. A 32-year-old male presents to your office with right elbow pain after a fall 2 days ago. He slipped on ice and fell on an outstretched hand. He's having difficulty moving the elbow since. Very common description, injury of an elbow radial head neck fracture. You can see here subtle non-displaced fracture of the radial head. And so these are best treated initially with a long arm splint, so patients aren't moving it right away. These are prone to displacement, and so protect them. And I usually see them in follow-up in a week or two, and get serial x-rays for about 6 weeks, tracking displacement, and really just educating patients. Can't lift with that arm at all for 6 weeks during the treatment period.
So next elbow fracture is an olecranon fracture. This was a 23-year-old that fell directly on the elbow. Is a minimally displaced olecranon fracture. These are prone to displacement. The triceps muscle attaches to the proximal olecranon, and any arm motion can pull the triceps and pull that proximal fragment away from the distal fragment, splitting the fracture. So you really have to immobilize these. A sling is not enough. You really have to put these patients in a long arm splint. And then when I see them back in a week, I'll re-x-ray, make sure it hasn't displaced, and I put them in a long arm cast for the non-displaced fractures. For the displaced fractures, they need to be fixed surgically. So this is another common injury seen in urgent care. 50-year-old gentleman presents to your clinic with right arm pain, weakness, and bruising after an injury 3 days ago. He's lifting a heavy object off the ground. He felt a pop, like something snapped. On exam, he has ecchymosis on the medial arm and antecubital fossa. He has a positive hook test. So you try to hook the distal biceps tendon and you get nothing there. And he also has weakness with resisted forearm supination. And if you look at the elbow picture here, classic presentation of a distal biceps rupture. This patient needs an MRI to confirm that it's a complete rupture. Sometimes they're partial that needs still to be repaired, but MRI can differentiate partial versus complete. And these typically need surgery within 2 or 3 weeks. If you wait too much longer, the tendon retracts, becomes much harder to fix, or we can't fix it at all. So make sure you get the accurate, timely diagnosis on this one. So I recommend a long arm splint for most elbow injuries that come into urgent care in the outpatient setting. Posterior long arm splint for any fracture, distal biceps rupture. The splint is placed on the ulnar side, starting at the hand and wrist, goes to past the posterior elbow and 2/3 up the humerus. The elbow is placed in 90 degrees of flexion. The wrist is placed in a neutral position, and instruct the patient to keep on until orthopedic follow-up in 7 to 10 days. Again, these splints aren't made to last longer than 7 to 10 days. The A strap comes unraveled, becomes loose, so it really needs to be seen within a week, and then we can take the splint off. Occasionally, shoulder dislocations will show up in the outpatient setting. This was a 29-year-old male who was involved in an MVA. He lost control of his vehicle, rolled over, something hit the front of his shoulder, and he had severe pain, unable to move the shoulder. And you can see here that the x-rays were actually read as negative. And he couldn't move the shoulder 2 or 3 weeks later. We ended up getting a CT scan, which showed there to be a hinged fixed posterior shoulder dislocation. So you have to be very careful on exam. A posterior shoulder dislocation will have very limited external rotation, where a anterior dislocation, they won't be able to internally rotate, just based on the way the humerus is hinged. For this posterior dislocation, you have a positive light bulb sign where the humerus is internally rotated, and you're seeing the greater tuberosity here. Really important to get a axillary view at all possible. I know it's difficult in some patients, but it's the best view to rule out a shoulder dislocation. And you can see here it's like a golf ball in a golf tee. Very clear that shoulder is not dislocated on the axillary view. So treatment of clavicle fractures, initial treatment should always be sling them and have them follow up closely in 1 week. Tell them to avoid any type of forward elevation or horizontal adduction of the arm. Basically, they can take the sling off to shower and sort of dangle their arm in a pendulum type motion to wash. Adolescent and pediatric fractures are almost always non-operative. This was a 13-year-old hockey player here on the left, treated non-operatively. Adults that are skeletally mature have, again, less remodeling potential, less healing. So fractures in adults that are really shortened over, say, 2 centimeters and 100% displaced with comminution, you could consider surgery in those patients. But almost always, adolescents, pediatric fractures are non-operative. So this particular study really changed the way we treated clavicle fractures in adolescents. 2022 study out of the American Journal of Sports Medicine 2-year functional outcome of operative versus non-operative treatment of completely displaced midshaft fractures. So these 100% displaced. They look terrible, look like they require surgery on x-ray there, but they concluded that surgery demonstrated no benefit in patient-reported quality of life, satisfaction, shoulder-specific function, or prevention of complications after completely displaced clavicle fractures in adolescents at 2 years after injury. So concluded that basically we don't operate on completely displaced adolescent clavicle fractures. So neck pain and cervical radiculopathy, when they present acutely, this was a 48-year-old female with severe right shoulder pain and neck pain for 2 or 3 weeks. You can see that she has cervical disc herniation here. Just recommend initial treatment. Always get an x-ray. Does the patient have arthritis? Is there any instability or a mass that you don't want to miss? Typically, I treat these patients with a 6-day Medrol dose pack. I've seen other providers use a short course of, say, 50 milligrams a day for 5 days, but those patients can have a rebound effect. Once they stop the prednisone, it can come roaring back. So I think the tapering dose works a little bit better. And if the pain continues after the dose pack, we can wait a few weeks and try them on maybe a longer Medrol dose pack, 2-week taper type treatment. Cervical traction can help with these. So when I see these patients back, and I would recommend having us see them in a week or two, I can initiate therapy for cervical traction and certainly document any weakness. If there was any weakness, I'd be more inclined to get an MRI sooner rather than later. Now, this can be also confused with shoulder pain as well. So it's good to treat them with the Medrol dose pack. Treats both shoulder pathology and neck pathology, and orthopedics can kind of figure out what's going on in a week or two after. So lower back pain, which I'll touch briefly on because we could spend a day doing this. Acute lower back pain, always get an x-ray. Don't miss a compression fracture, a tumor, something odd incorporated. Huge differential diagnosis in lower back pain, from radiating pain from disc or stenosis to facet joint pain, to spinal instability or just muscle spasms. Initially start with a Medrol dose pack, tapering dose 1 week. And follow up with orthopedics in 1 to 2 weeks if the pain continues, to initiate therapy, review images, and really to help motivate patients, really, because the bottom line is the worst thing you can do is hit the couch and become a couch potato. You have to work through this, get into therapy, lower extremity stretches, core exercises. It's just going to get worse if you sit it out. So moving on to hip pain, 42-year-old male presents to your office, 2 months right hip pain. He's having difficulty bearing weight on the right side. He fell on the hip after slipping on ice a few months ago, and moderate pain in the hip since. The initial hip x-rays taken at the time of injury were negative for a fracture. So this patient actually was sent for orthopedic follow-up, continued to have pain. We ended up getting an MRI, which showed a femoral neck stress fracture. This patient ended up having surgery and had a couple screws placed in his hip, and definitely at risk of that displacing. So if it's unclear, initial x-rays are negative and you're still concerned, you can use crutches with early orthopedic follow-up. So to touch on the pediatric hip, this is a quick case. 11-year-old female presents to your office with 1-month history of left hip pain. The pain started after a dance class 1 month ago and has continued since. The patient and mother thought the pain was a muscle strain and did not seek medical attention. On exam, the patient walks with a limp supporting the left leg. You get an x-ray, lateral view showing there to be an unstable, slipped capital femoral epiphysis. These patients need to be strict non-weight bearing initially, put them on crutches, and send for orthopedic follow-up within 3 to 5 days. Recommended treatment is a percutaneous fixation. Bottom line for pediatric hips, always get an x-ray, wide differential from hip dysplasia to transient synovitis to septic hip to leg calf Perthes disease or avascular necrosis of the head, SCFE, tumor, juvenile RA, avulsion fractures, and more benign hip flexor tendonitis. So knee injuries are very common presentation, urgent care settings, outpatient settings. These x-rays were from patients with knee injuries where they felt a sudden pop from a knee extension, jumping and squatting. They were unable to straight leg raise when they came in on exam. And you can see here, top right, you have patella alta, where the kneecap is higher than normal, indicates a patella tendon rupture. And on the bottom right here, you can see it's patella baja. And when I think patella baja, California or below, that's the patella is below where it should be. That represents a quad rupture, and you can see a little bony avulsion here. So if they're unable to straight leg raise for any reason, you need to put them in a knee immobilizer and crutches. They can put weight on it if they have the knee immobilizer on because you don't activate your quad, but they need early orthopedic follow-up if they can't straight leg raise. And any knee injury, collateral or ACL injuries are a little bit more obvious on exam. Put those patients in a hinge knee brace, crutches with early orthopedic follow-up. This is a 15-year-old male that presented to urgent care with left knee pain. He was playing football, tripped, and struck his knee against the cement wall. You can see here he's got a patella fracture. Recommended treatment for any patella fracture, crutches, knee immobilizer, and early orthopedic follow-up. These definitely can displace. If there's any disruption in the quadriceps, the patella tendon, this represents the extensor mechanism of these three structures. Any disruption of these structures causes an inability to straight leg raise. So if the patient can't straight leg raise, suspect an injury to the extensor mechanism, put them in a knee immobilizer. Next, moving on to ankle fractures. The one question I get a lot is, can I let the patient weight bear with this ankle fracture? In general, really, the patients that can walk on them are patients with non-displaced isolated distal fibular fractures. And now these isolated distal fibular fractures, if there's no medial sided tenderness, no tenderness over the deltoid, so you palpate the inside of the ankle, no tenderness over the anterior syndesmosis, and no pain with external rotation of the ankle. This stresses the syndesmosis. So if all these key exam findings are normal, non-displaced fibular fracture, they can weight bear. Otherwise, you will have to put them in a boot and crutches with orthopedic follow-up in 1 week. So definite unstable fracture patterns include bi and trimalleolar fractures. You can see here we have a trimalleolar with the lateral, medial, and posterior malleolar fractures. Bimalleolar, trimalleolar, and isolated posterior malleolar fractures are unstable injuries and prone to displacement. Bimalleolar and trimalleolar fractures treatment. Healthy patients that are active have a risk of instability and post-traumatic arthritis with non-operative treatment. So surgery is recommended for bimalleolar and trimalleolar fractures. These are unstable injuries. Initial treatment, place them in a splint or a boot, non-weight bearing, and follow up in 2 days with orthopedic follow-up. Because if they do have surgery, it has to be within the first 2 or 3 weeks. A syndesmotic injury is an injury that can often be missed. This is an 18-year-old presented to the office with significant pain, inability to bear weight in the left lower extremity and ankle. You can see here he's got a fibula fracture, minimally displaced, but also has medial clear space widening, indicating a syndesmotic disruption. Very subtle finding on the x-ray. The patient was treated with open reduction and internal fixation. Definitely needs to be non-weight bearing with initial treatment, placed in a boot or a splint. To touch on fifth metatarsal fractures, very common in presentation in the urgent care setting. Really important to differentiate Jones versus pseudo-Jones. You can see here to the left, a Jones is a fracture of the metaphyseal-diaphyseal junction, prone to non-union as it has a very poor blood supply. Pseudo-Jones is off the tip of the fifth, proximal tip of the fifth metatarsal where the peroneal brevis attaches, and it is prone to displacement as the tendon attaches to it and you move the ankle, it can pull that piece proximally. So very important to treat in a boot. So Jones fracture needs to be non-weight bearing, can take up to 2 or 3 months to heal. Any type of weight bearing can displace it and increase risk of non-union. But the pseudo-Jones you can walk on, but you have to use a boot because you can't roll the ankle, which can displace the fracture. In general, metatarsal fractures can be treated weight bearing as tolerated in the boot as well. So this guy here is one of my best friends, the tall walking boot. We don't use a lot of casts
for foot and ankle injuries anymore unless the patient's completely unreliable, that they're just going to take off the boot and not use it at all. We can cast those patients. Otherwise, the boot is very functional. You can take it off to ice and for hygiene. Use it for non-operative fractures. If they do have an unstable operative fracture, I prefer fiberglass splints because they can't take it off, and they will definitely be more inclined to follow up with orthopedics. I use this boot a lot for foot and ankle tendonitis, plantar fasciitis, arthritic flare-ups, just about everything. With the point being, it completely immobilizes the foot, doesn't allow you to push off. It rests and immobilizes the extremity, which is generally enough for to help with treatment for a lot of different tendinitises and arthritis flare-ups. So to finish up, some take-home points. Always get an x-ray of an injured joint or extremity. You'll stay out of trouble by getting the x-ray. You can get in trouble if you don't, so always get one. Don't rely on an x-ray report. The radiologists that read these cannot examine the patient, so look for the point of maximal tenderness. I tell patients, point with one finger where it hurts the most. They'll point to it, then you look on x-ray where the point of maximal tenderness is, and that's where you'll find your pathology. Don't look at bad x-rays. Ask the tech to repeat the films if you can't see a true joint line, a true AP and lateral. As you can see on this right, you can clearly see a nice Grashy view, nice joint line. Don't send every fingertip amputation to the ER. These can be managed outpatient and sent to a hand surgeon or orthopedic follow-up in 2 to 3 days appropriately with a wet to dry dressing. They don't have to wait in the ER for 6 hours just to have them sent home. Don't be afraid to x-ray the contralateral pediatric elbow to see what's normal. So obviously a lot of growth plates in a pediatric elbow, very difficult to tell what's an avulsion injury, what's normal anatomy and what's growth plate. So don't be afraid to x-ray the contralateral elbow and to compare the injured side. Pediatric distal radius and forearm fractures can tolerate some displacement due to remodeling potential. So these don't have to be perfect. You can splint them, send them to orthopedics. They're fine. They'll heal well with remodeling potential. For ankle fractures, the only non-displaced fibula fractures without medial tenderness can weight bear as tolerated. Those are the stable injuries that won't displace. Otherwise, other fractures, trimal, bimal, isolated posterior mal fractures, they need to be non-weight bearing on crutches. And finally, use a tall walking boot for non-displaced, stable ankle and foot fractures. Post-op shoes to the right, I see them all the time. They should only be used for toe fractures, phalangeal fractures. They just don't offer protection for metatarsal fractures, ankle fractures incorporated. I appreciate you all listening to my talk, and if you have any questions, please shoot me an email. Thank you.